Yes, General Secretary, Ministry of Health, Republic of Indonesia. Uh, okay, time and floor is your Bapak, whenever you're ready.
Thank you, moderator. Good morning, good afternoon, good evening. Thank you, Pak Agung. Excellencies, distinguished ladies and gentlemen. I'm delighted and honored to be able to attend, even though only virtually, and deliver my remarks at this extraordinary event. As we all know, mental health problems have become one of the most prominent health problems in recent years, especially triggered by the COVID-19 pandemic. Mental illness and its effects have become a major challenge for any health system. Mental health is strongly linked to other development factors such as poverty, employment, and economic growth, of peace and justice. Mental health plays a key role in achieving social inclusion and equity, universal health coverage, access to justice and human rights, and sustainable economic development. This mental health problem is not only experienced by adults, but also occurs in young people, including adolescents and school-age children. This fact is certainly very worrying because these children are our future. We cannot imagine what the future will be like if many young people suffer from mental health disorders. Therefore, maintaining mental health from an early age is a must and our shared responsibility. The problem that is often found in the mental health of adolescents is suicide. Based on data from the Global School Health Survey, it was found that 5.14% of high school students on the equivalent had suicidal ideation in the last 12 months. 5.54% had planned suicide, and 3.86% had attempted suicide. Therefore, it is necessary to make efforts to prevent and treat suicide with this pursuit with well-coordinated cross-sectoral cooperation. Strengthening cross-sectoral surveillance and monitoring systems will assist the development and implementation of suicide prevention and management programs. In Indonesia, the prevalence of depression is 6.1%, and the prevalence of mental emotional disorders is 9.8%. Meanwhile, the prevalence of severe mental disorders, or ODGG, is 0.18%. Mental health disorders accounted for 4.36% of the total burden of disease. This is a fairly large number. It will affect the quality of life and productivity of the population. Although currently the cost of treatment for mental disorders can be borne by BPJS Kesehatan, patients and their families still have to bear the cost of transportation and other costs to get to the health service. To reduce the risk of mental health problems, every individual, family, community, and government need to increase early detection of mental health disorders. Patients need to be helped to seek treatment until they recover. Mental health services cover the entire human life cycle from premarital to old age, so that comprehensive services can be obtained. Here, I appreciate this event because the discussion and dialogue that will be carried out by Yakum, supported by United Global for Mental Health as part of their Health and Vaccine Working Group and C20 plans to hold a Stadium General on universal health coverage to provide knowledge for C20 members and make them aware of the importance of mental health. I really hope that this event is initiated by civil society, and here is Yakum, that contribute to mental health to integrate mental health in the C20 policy package, which will later be submitted to the G20, where Indonesia is currently the G20 presidency, especially in achieving SDGs. Finally, I would like to thank Yakum for organizing this event. I hope that the good cooperation between the government and civil society institution or organization can continue in the future. This all from me. Thank you, and I hope you can have a good discussion. Over to you, moderator.
Thank you once again, Bapak, for your support, and within very tight schedule, you still can be here with us. Okay, let's now proceed to our next agenda. We will hear a presentation on how mental health issue can be integrated in universal health care. It will be delivered by Professor Helen Herman from Center for Youth Mental Health, University of Melbourne. And during discussion, it will be chaired by Ibu Arsinta from Yakum. While we're waiting for Bu Sinta's ready, I need to kindly remind you for all the attendants here in this room that we have coffee and snacks at the edge of these rooms. Okay, Bu Arsinta, are you ready?
Yes.
Okay, over to you.
Thank you. Good morning and good afternoon, good evening from some colleagues in the other side of the globe. Thank you very much for the General Secretary of the Health Ministry of Republic Indonesia, Bapak Kunta Wibawa PhD, for giving us some foundational points to look at and to consider when we are talking and discussing the UHC and mental health. The G20 holds a strategic role in securing future global health and prosperity. Together, the G20 members represent more than 80% of world GDP, 75% of international trade, and 60% of the world population. Having G20 presidency in Indonesia is an important opportunity for us to turn the tide on important health issues such as mental health. And we also read from the chat box that our coordinator Rachel Ong also reminded that this subject has been also presented in the previous G20 in Italy. The Civil 20 or C20 is an official G20 engagement group consisting of civil society organizations across the globe. The Vaccine Access and Health Working Group, chaired by one of it is Mas Agung, that has also delivered his remark, has 4 priority issues, namely global health architecture, expanding access to health and COVID-19 commodities, universal health coverage, and strengthening the public health ecosystem. In coming 2.5 or 3 hours, we will have very interesting studium generale about mental health and how it is actually be integrated in the universal health coverage. There will be 2 rounds of session, colleagues and friends. The first one is to listen and study together with Professor Helen Herman, who will equip us about mental health and why it is highly relevant to global health. The second round, we will hear sharing from Mrs. Francesca Guaves and Dr.Samrah Mazhar on country-specific context where mental health is integrated to the universal health coverage framework. With these 2 sets of sessions, we hope colleagues and friends from C20 will be equipped to develop concrete recommendations when the world will have to build global health system resilience within global health architecture for us to recover together and recover stronger. Colleagues and gentlemen, allow me to introduce you to our first speaker, Professor Helen. After I myself have been hearing her name a lot in global arena in mental health, I think we are lucky now today to have her here with us this morning. Helen Herman is Professor Emeritus of Psychiatry at Origin and the Center for Youth Mental Health, the University of Melbourne, and she is also the Director of WHO Collaborating Center in Mental Health, Melbourne. Prof. Helen is former President of the World Psychiatric Associations from 2017 till 2020, and also the International Associations of Women's Mental Health. She is appointed an officer of the Order of Australia. Her research and development interest as psychiatrist and public health physician includes promoting mental health, community mental health care, and women's mental health. Previously, she was professor and director of psychiatry in St. Vincent's Health, Melbourne, and for a year acted as regional advisor in mental health for the WHO Western Pacific region. She led the WPA's action plan for 2017 till 2020 and concerned with supporting the contributions of psychiatrists to global mental health. Publications include the report as chair of the Lancet WPA Commission titled Time for United Action on Depression, published in 2022. Without further ado, I will give floors to Prof. Helen. Prof. Helen, you will have 45 minutes maximum for your sessions, and it will be then followed up by 15-20 minutes question and answer. Time and floor is yours, Prof.
Thank you, dear colleague Shinta, and I appreciate the invitation from Yakum and the C20 working group to this important session, and appreciate the remarks from a colleague from the Ministry of Health in Indonesia as you host this session in your country. So thank you once more for the welcome. I'll now begin some remarks as you invited, and will share my screen to do that. So I'm trusting that is happening.
Yes,
there
it's
we
coming.
are. Thank you. So, as already stated, it's a very welcome moment to be considering the relevance and importance of mental health to universal health coverage, to achieving universal health coverage and the improvement of mental health of the populations of our communities, as well as good health more broadly and the capacity to achieve sustainable development. So I think these are the concerns that we all share. So mental health is becoming more part of the awareness of many people around the world as we go through many global difficulties at this time, ranging from the COVID-19 pandemic to conflicts around the globe and the mass displacement of peoples inside countries and outside, as well as all of these worsening the inequities that are making life difficult for people in many countries or most countries across the globe. And here in Indonesia, mental health has been a significant part of the work. Listening to the remarks just made from our colleague in the Ministry of Health illustrates how thoughtful the work is in Indonesia. And this was brought to attention particularly in 2004 and 2005 in the wake and beyond in the wake of the Indian Ocean tsunami that particularly affected parts of Aceh and other parts of the country as well, and many parts of the Indian Ocean region. And the community activism, particularly the women and the young people and the men, recognizing that health, mental health, social conditions, social connections are all closely interconnected. And along with this have gone over the years many activities in your country, in Indonesia and other countries, as well as around the world, to break the stigma, to make people more aware of mental ill health and its ramifications, as well as the value of mental health. So I'll make a few remarks in the next half hour or so on mental health and mental ill health around the world, and consider the determinants of mental ill health, many of which are social determinants, and how the importance of mental health becoming part of universal health coverage and taking account of community participation and sectors beyond as well as within the health system, and how the importance of community support and partnerships and how they bring mutual benefits and to health and development. So I'll talk first about global mental health and how the attention to this in the time of the COVID-19 pandemic has been accentuated. So at the beginning, 2 years ago, as the pandemic really began to affect people's lives across the world, the United Nations Secretary General policy brief called for redress of the historic underinvestment in mental health to reduce immense suffering and mitigate long-term social and economic costs to society. So this was partly a worsening of the problems of mental ill health in many parts of the world, as well as drawing attention to the existing significant problems that existed. And UNICEF, in its annual State of the World's Children report at the end of last year in October 2021, for the first time devoted this report to mental health. So it commented that despite widespread demand for responses that promote, protect and care for children's mental health, investment remains negligible. And as said by the previous speaker, children are our future, and they are among those experiencing significant mental distress, as well as suicidal ideation and behavior. So I begin, before turning to mental ill health, begin with mental health. Often the terminology is used interchangeably, which can lead to confusion. But if we think of mental health, just like health in general, it has value. It enables us to do things, to be who we can be and want to be. And it is something that can be improved as well as taken from us. So mental health is a state of well-being. It's inseparable from physical health, and it's more than the absence of disease. As mentioned, it can be improved, just as a physical health can be improved through physical training and through diet and exercise of various types. So we can improve mental health partly through improving the conditions in which people live, that making them more conducive to mental health, as well as through some individual choices at times. And the attributes of a mental healthy person are universal. So this is a state of well-being, as mentioned, where people can cope with the ups and downs of normal life, can be productive in their work or study, and maintain satisfying relationships with other people. Despite this universality, the expression varies culturally. I think that is evident to many people, but needs stating. But throughout cultures across the world, social connection is at the core. And this is exactly what is being threatened by the pandemic and by the other disconnections and catastrophes around the world. So I turn to people from my own country, the First Nations of Australia, who describe social, emotional, and spiritual well-being and the connections to land and ancestors, in addition to the people around them and their culture, contemporary culture. And the family and working life and the direct effects of the infection in the current pandemic, as said, are disrupting these very foundations of good mental health. So turning to the global burden of mental ill health, there's a high burden of disability worldwide, that there are common mental conditions such as depression and anxiety, and we would include alcohol use disorders among those. And less common conditions like schizophrenia and other psychoses or bipolar mood disorders and eating disorders. These conditions are also very important, and even though they affect a lower proportion of the population around the world, they cause a great deal of disability and distress for the people experiencing these conditions and their families. But mental health, particularly depression, anxiety, alcohol use disorders, has worsened during the pandemic. There's been an increase in help seeking and an increase in mood and anxiety disorders. And we see that same increase among people exposed to conflict and people exposed to displacement. And during the pandemic, those living with severe mental and substance use disorders were found to be at high risk of COVID-19 infection and high risk of death if they did contract it. So just as people with other health conditions such as diabetes or lung diseases had a similar experience. It's worthwhile noting the epidemiology or the pattern of occurrence of mental disorders across the population. The focus on young people is relevant because the time of greatest onset or the highest incidence is in young people, particularly those in the second and third decades and fourth decades of life. This is quite different from other non-communicable diseases. If we think of heart disease, diabetes, cancer, that is more common in people in their 6th, 7th, 8th decades in life and beyond. And of course, important and significant mental disorders, including dementia and many situations, people with depression can occur late in life and need close attention. It's the overall onset of depression, anxiety, psychosis, and other conditions in young people that leads to disruption in their further lives and disability, as well as higher death rates. And 75% of people with lifetime psychiatric disorder experience its onset before they're 24 years of age, and then experience sometimes tumultuous lives where that tumult could be avoidable. And children who are maltreated are particularly prone to this, although not restricted to that group. But psychosocial adversity and mental ill health go hand in hand, and poverty, gender discrimination, and discrimination of other kinds, violence in the home or outside the home, in the streets or in a situation of conflict, and social exclusion for any reason, they're causes as well as consequences of depression and other mental ill health. But none of these factors acts alone. And they're all part of a web of interacting personal and environmental factors that can protect from as well as contribute to the risk of mental ill health. And living in slums or refugee camps, as well as the experience of maltreatment or of disasters, all promote the likelihood of mental ill health, including depression, anxiety, and other conditions. And there is a cycle of social disadvantage that's particularly important in mental ill health, although it's also noted in health more broadly with the interaction that that brings as well. And this was noted 25 or nearly 30 years ago by a group led by Professors Leon Eisenberg and Arthur Kleinman at Harvard Medical School. And they published an important report, World Mental Health, related particularly to low-income countries, although its relevance is there for groups in all countries. But poverty, violence, and discrimination in poor neighborhoods, chaotic environments, lead to high risks for mental ill health. And mental ill health, in turn, provides additional barriers to health and to employment and livelihood and to further education, which in turn make worse poverty, violence, and often the discrimination that goes with distress and fear. So breaking this cycle is important through social action as well as healthcare action, even though sometimes the odds and the obstacles seem overwhelming, which is where we need united and multiple types of interventions. So the premature mortality associated with mental ill health of most kinds is referred to poignantly here by John Steinbeck. So a sad soul can kill you quicker, far quicker than a germ. And this relates to increased risks of suicide for people with depression and other forms of mental ill health. But it also relates to the high rates of coexisting physical disorder, such as cardiovascular disease and diabetes and cancer, as well as the combination of one or more mental disorders and substance abuse. Despite all this, most people with mental ill health still receive either no care or inadequate care in any of our health systems. This is a graph related to contact with services for depression care for people living in the community across 15 countries, a combination of high income and low and middle income countries. You can see in the blue column there on the left that even in high income countries, only 1 in 2 people with a treatable mental disorder will reach contact with the service. And in low and middle income countries, it's half that number, 1/4 of people. But if we look at the provision of adequate combination therapy, in other words, how acceptable are the treatments, but in particular, how much the health services can be aware of or deliver adequate therapies is much reduced again. So only 1 in 8 of people in high-income countries receives adequate combination therapy for an episode of mental or a life course of mental ill health, and a tiny fraction of people in low and middle income countries. So there are myths about depression, myths about mental ill health in general, such as it's a personal failing, it's an invention of biomedicine, or it's a culture-bound condition. And these all prevent people seeking care, or they curtail its provision. They curtail the training, the resourcing, and the imagination and systems design. And the associated stigma of having these conditions and aiming to seek care, it's keenly felt by people with the condition and their families. And for those, also those in the health system or the social systems that seek to offer support. And the former Prime Minister of Norway describes this eloquently. He's spoken openly of his personal experience of living with depression and regards stigma as the main problem as a barrier to improving the mental health situation in countries. And he aims to combat stigma by telling his own story in these ways. So we need to find interventions at multiple levels to reduce the burden of mental ill health globally, to consider public understanding and political will, to drive promotion of health, of mental health, along with the promotion of health more broadly, and the prevention of mental ill health, which is possible in many different ways at societal and individual levels, as well as provide access to effective care. And all of this, I understand, is within the domain of universal health care, and both universal health care and mental health of our communities will benefit from their interaction. So now, as a word about universal health coverage, that the World Health Organization has described this as all people having access to the health services they need without financial hardship. And they also note that at least half the people in the world don't have the health services they need. And millions, 100 million people annually, their estimate, are pushed into extreme poverty because of out-of-pocket spending on health. So this idea of universal health coverage, which is a current WHO priority, comes also out of an earlier movement for many of you would be aware of described as Health for All by the year 2000. And this came with the declaration of Alma Ata at a meeting convened by the United Nations, including WHO, in 1978. The fact that we don't have health for all by the year 2000, was that a failure of the aspirations and policies and processes of that movement? Or does it mean that we need to continue and enhance those efforts? So the idea of Health for All was to provide a comprehensive, universal, equitable and affordable healthcare service for all countries, surely an important as well as a noble aspiration. There were several parts to that declaration that I think are relevant to our discussion today because they're common to the inclusion of mental health in universal health care. That health being a state of complete physical, mental and social well-being. This is the original WHO definition of health, of course, from 1948. The declaration included the concept that health inequities are unacceptable, especially between countries of different income levels and different cultures and backgrounds. that economic and social development is necessary for health. And I think in the era of the United Nations Sustainable Development Goals, we're used to thinking about the converse of that, that health is necessary for economic and social development. And within that, mental health is an essential part of health as well as economic and social development. The next idea was that lay participation was essential to planning and implementing healthcare. And there was a right for that to take place, as well as a duty for lay participation to be enabled and encouraged. Governments are responsible for healthcare, as well as measuring health and social well-being and responding to that. And primary healthcare is the local, universally available and essential first point of contact. It needs to be adapted to each environment to be practical, scientifically sound, and socially acceptable, and technology at an appropriate cost and type for the country and the setting, and that community participation is essential. Now, this the decision was made to renew and enhance health for all under the title of universal health coverage. And a new gathering was held in Astana, Kazakhstan, the new name for Alma-Ata, in 2018 to renew a commitment to primary health care to achieve universal health coverage and the Sustainable Development Goals. And by primary health care, this was a term that included health services, but also the access to good quality needed services and conditions that might go beyond the health system and result from community action in particular, as well as health policy making and social policy making. So that included health promotion that includes social policies and action, prevention of ill health, treatment, rehabilitation, and palliative care, and financial protection. No one facing financial hardship or impoverishment because of needing to pay for services. And this should apply to everyone, wherever they are. But turning now to come back to mental health in the context of universal health coverage, how they are beneficial to each other. Well, a document was released in 2018. It's available on the Lancet Journal website, the Commission on Global Mental Health and Sustainable Development, that put together these two concepts of, it reframed mental health and looked at the way that the social and the biological determinants of mental health problems interact across the life course, this interaction of nature and nurture from before birth, during childhood and young life, and throughout the subsequent life course. And it describes mental health as a fundamental human right, especially for people whose mental health is at risk or impaired. Now, this is quite a detailed diagram, but I don't think you need to see all the detail. But the concept is that this is describing protective and risk factors in the early life course for mental health. So the top line here, the blue line, is for a trajectory, a mentally healthy trajectory, beginning with healthy parents, mother-infant stimulation, secure caregiving and positive parenting, the availability of cultural and recreational activities, and supportive peer groups. And preventive interactions can attempt to enhance all of these, such as promoting social networks and life skills programs in schools to promote emotional competencies that are promoted by WHO, as well as improvements to school climates. Then there are the at-risk groups. There may be psychological treatments or environmental interventions possible for these groups. and taking note of the factors that are likely to lead to poor mental health, beginning with substance abuse during pregnancy, the pregnancy being unwanted, and there being inadequate prenatal care, and difficulties with nurturing and stimulation of the child, and problems as life proceeds. And here, interventions, treatment and recovery interventions are vital, particularly early in life at individual and community and societal levels. This commission also made it clear that we, as well as reducing the treatment gap for mental ill health, it's important to consider this promotion of mental health through collective and or interventions at different levels, and reducing the burden of mental and substance use disorders through considering prevention and the quality of care, taking care out of institutions, replacing coercive care with good quality mental health care in the community, and engaging people living with the conditions and their families closely in personalised and collaborative care, which I'll say a few words about in a moment. So the message of this commission was that there are cost-effective solutions to mental health care, but mental health can also be improved through interventions beyond the health sector, whether that be in families, schools, workplaces, and poverty alleviation. And with a warning too that without action on mental health, the Sustainable Development Goals can't be met, and that improving mental health improves education, it improves gender equity, poverty alleviation, and climate action. There's positive interaction between all these factors and mental health. So what are some of these effective interventions? Well, at the healthcare level, the WHO high-level commission time to deliver on non-communicable diseases and mental health was released in 2018. It details evidence-based synergies in prevention, treatment and care for mental and physical health. So all of these conditions co-occur, as I mentioned earlier, and they each can exacerbate one another, or relief of mental or physical ill health produces better possibilities for relief or treatment of the other. Intervening in childhood and youth is important when disorders accounting for most of the global burden of ill health have their onset. And thinking about trauma, whether that's from violence in the home or elsewhere, maltreatment of other types, and associated mental health problems is very important for improving the possibilities for effective work across health and welfare services, and for working in schools and criminal justice systems. So what is now sometimes called trauma-informed care, which really is a personalised listening and a close awareness of what has the background of the people engaged and what may be triggering behaviours at the time. A publication across all of healthcare included a chapter on best practices for mental, neurological and substance use disorders a couple of years before that report. And it's useful to note that at the population level, the best buys or the best practices for reducing these disorders at a population level were restricting access to the means of suicide, so pesticide control across many countries, or restricted access to bridges that have been points of people losing their lives, and reducing the availability of and demand for alcohol, which has also been a focus for strong community action in many countries. At the community level, that life skills training in schools to improve social and emotional competency, and at the healthcare level, promoting self-care, whether through new digital technologies or book therapies in other ways, as well as the enabling of capacity in primary care and community outreach, particularly through task sharing and collaborative care. And the WHO has a mental health action plan, which has now been extended to 2030. And strengthening effective leadership and governance, providing these comprehensive, integrated and responsive health services and social services in community-based settings. It quite clearly states implementing strategies for promotion of mental health and prevention of mental ill health, and describes this as integrated with universal health coverage, as well as the vital point mentioned earlier of strengthening information systems, evidence and research. And in terms of that third strategy, the aspiration for the target for 2030 is that 80% of countries will have at least 2 functioning intersectoral mental health promotion and prevention programs. The rate of suicide will be reduced by 1/3 through actions at multiple levels, whether that be reducing the means, follow-up for people treated for suicidal behaviour, good treatment of mental disorders, reduced gender discrimination. And the third is that 80% of countries will have a system for mental health and psychosocial preparedness for emergencies or disasters. And just to mention that the United States, just as the pandemic was beginning, released a very useful report that draws and it illustrates many of these concepts on fostering healthy mental, emotional and behavioural development in children and youth, and talks about the complex neurobiological processes that interact with the physical and social environment throughout the life course and across generations. So despite all that, mental health expenditure globally is very, very small. 2% of government budgets for health and 1% of global development assistance for health, according to the WHO Atlas and WHO reports. That's all. And that 4% of global health research funding is devoted to mental health. And very little of that goes to low and middle income countries or to the evaluation of public health interventions. So this is vastly out of proportion to the burden of mental ill health where we know that depression is now the second most prominent cause of health burden in the world. So another report was released earlier this year, Lancet World Psychiatric Association Commission, Time for United Action on Depression. And this, because depression is the most common mental disorder, is relevant to us here. And many of these comments relate to other mental health conditions as well. So 1 in 20 people experiences depression in any one year. And depression is a common health condition, but poorly recognized and understood. And across the lifetime, 1 in 5 of us will experience it. So almost every person or every family has some encounter with this condition. It's universal. It's been described across the ages and across cultures. And prevention is key to reducing the burden. A whole of society interventions at the top to address the structural determinants of health, such as poverty alleviation and reduced discrimination against women and girls, allowing them an education and autonomy in community. And it can be in settings, family support, school climate changes, school curricula as mentioned, across workplaces, making these mental health friendly, across neighbourhoods, increasing social connections, whether that be for young families or for older people, and in health services, improving the capacity of health services, particularly at the primary care and community level, to understand how to assist. And then individual and family interventions of all various types across the life course, whether that be the experience of bereavement for older people, social connection, antenatal care that's responsive and listening, support for families, and so on. In closing the care gap needs to include engaging with the people with this lived experience and their families, as well as other people in communities, and the use of task sharing of less trained workers working with community outreach and with support and training from mental health experts. This has been implemented successfully in many settings now across the globe. But all of this requires a collaborative care delivery models, and these focus on delivering health and social support and suicide prevention across families, across health services, and engages mental health specialist teams, primary health teams, lay workers, and cross-sector providers in education, urban planning, criminal justice, whatever, that they are interacting with each other. And these systems have been studied in various countries of various types, and there is evidence base for their work. So this boils down to a whole of society engagement into translating what we know into practice, the general community, healthcare practitioners, decision makers and researchers. And investing in depression care, and we could expand that to mental health care in general, represents excellent value for money and contributes to the attainment of not only of the Sustainable Development Goal 3 for good health and well-being, where it's mentioned specifically, but also to poverty, to zero hunger, to quality education, gender equality, and so on, including climate action. So this is a message of hope. It synthesizes the evidence on what can be done to prevent and care for depression and other mental disorders, but how interventions like this can be implemented even in the least resourced context, can be integrated with wider health and social systems. And the evidence that we have in all these conditions create an opportunity for united action to transform mental health globally. I have a few more thoughts on social policies, health and community development, but I think all of you are many of you are more expert than I am in community development. So I'll just move very quickly through to say that just as in the rest of universal health coverage, just as in the rest of community development, we rely on the processes of community engagement, of role models. Look what these young women have done for climate action and education for girls respectively, and how their example is how they inspire and encourage action. And to say that the participation, the essential ingredient for community development, this community-led development requires self-confidence and good mental health to tackle social and health goals like maternal and child health, violence in the home and community, alcohol use. But it also promotes good mental health. So this virtuous cycle of community members taking action on things important to them with advice from experts as they require it, and policy making, as well as their own actions. And we can consider depression in the perinatal period as an example, where we need to protect women from insecurity, poverty, gender discrimination, and particularly violence at the home, in the home, an important risk factor for depression in the perinatal period, which in turn is a problem that affects 1 in 5 women across the world, even more so in low and middle income countries than in high income countries. And that reducing these problems for women will go a long way there, and in turn enhance their ability to nurture and promote the development of their children. Failure to thrive is affecting up to 1/4 of children in parts of the world, including South Asia and parts of Asia. And an important factor in that has been shown to be maternal depression and ill health. And the second way we can prevent depression in the perinatal period is increase its capacity to work in primary care through collaboration and participation with women and their families, and the sharing of tasks with community workers and midwives so they become aware and confident in what they can do, trained and supported by practitioners who can provide support in the moments when they need extra help. And this has been proven by programs in Pakistan and other parts of the world to be effective. So we'll conclude that mental health is everyone's business. We need to strengthen the capacity of communities to respond to mental health needs. Be aware that the social determinants of poor mental health are amplified by inequity and conflict and the pandemic in current terms, so that these poverty, violence and discrimination are at the root of much of what we're dealing with. But on the other hand, that mental health is supported by and supports sustainable development. And all of this is part of universal health coverage, together with collaborative care and early intervention across the life course to prevent that avoidable disability that can occur from early onset of poor mental health. Thank you.
So thank you so much for your we have probably 15, 20 minutes for colleagues and students, particularly or the ones that are inside in this room, to give questions, reflections from the audience. So I open the floor for 2 questions first.
I'm sorry, I can't hear.
Yes. Can you hear from Helen?
I hear you just faintly now. Thank you.
Hello.
Yes, thank you.
Yeah. Thank you for the sorry for this technical challenge. Yes, colleagues and friends, you have to we will have to persons to give questions, Anyone? Be virtually or the ones that are existing. I will check the chat box. This silent moment can also give you time to also drink a cup of water, Prof. Helen.
Thank you. I will do that.
Yes. Otherwise, I think if I do not see anyone, I myself have, oh, Rachel, sorry.
Hi, good morning, everybody, and thank you for the very in-depth presentation, which is really appreciated. My name is Rachel Ong. I'm one of the coordinators with Agong on the Vaccine Access and Global Health Working Group of the G20. I just want to add on to fully support the presentation you made, and to actually also emphasize the importance of social determinants as one of the contributing factors towards the state of well-being of mental health. I just want to add that social determinants it is a vicious cycle, because in many diseases, for example, where there is already a lot of social stigma and discrimination, it adds on to stresses and anxiety for mental health. For example, for people who use drugs, for example, sex workers who are already facing huge discriminations, LGBTQI communities, people living with HIV, for example. So I just wanted to add to this that it is seen as one of the comorbidities for the work that we are doing in certain degrees. And perhaps you could elaborate a little bit more about conversations in this arena to help us in terms of the work that we're doing for the G20. Thank you.
Yes, thank you very much. That's the including the interest in and awareness of mental health in those settings is critical, as you describe, in preventing and managing HIV/AIDS, in perinatal care for a start, but in people with other health conditions, and particularly those with substance abuse. And understanding that it's not a side issue, just as you said, but it's part of the vicious cycling. People often give up in these conditions almost and say, what can we do when someone is burdened with poverty, living with violence, has other health conditions? What can we achieve? We're better to put our resources either into other groups or into other aspects of the care for these people. But without attention to mental health, it's very difficult to tackle many of the other problems. And also, these are the people who most need the mental health care most often. That even I know in high income settings where there are people who are living homeless on the streets or have a substance abuse problem, that no sector feels they can act. The people in mental health say, we can't treat you until you have your substance abuse problem solved, or we can't treat you until you have a stable home. And the housing sector will say, we can't take you in while you're addicted or have a suicide risk. So it is a matter of collaborative care very closely. I'm ready to comment further if you wish.
Thank you. I read one questions that actually related to the previous questions and also your previous statement, Prof. Helen. There is a question from Andre Hapsari from IAKUM, thanking you for the explanations, and she would like also to ask you what actually things that can be done to shift the paradigm for institutional based care for mental health to we call it panti, like center, to the community-based mental health care? What are the things that need to be done? Over to you.
Yes, thank you. Well, that's a critical question that many countries have begun to tackle, but we know that sadly, not only do large institutions remain, but the conditions within them are poor for providing personalised care and recovery. With often the unnecessary use of coercion is prominent, rather than we know that effective humane care can provide the conditions for recovery. So it's a whole combination of policy across health. The provision of adequate community services, the provision of adequate social support, the provision of adequate family support, so that the institutional care sector can be reduced, their resources directed to it can be lessened, while maintaining an increasing quality of care for those that remain there. But it's critical to have that community sector adequately sustained. But all of that underpinned by community awareness and political will. And living in awareness too, that in many countries, it's not only the institutions that are a major problem in human rights terms, but also people who receive no treatment at all, people living with psychotic conditions who are often chained in the communities, families that have no option but to restrain their family members in a room in the home, often for years at a time. And we need that political will and community action to understand, for a start, the value of mental health, but to overcome that stigma, that sense that we can't do anything. I think the main messages to come through need to be that there is effective action, that mental health is part of health, and that working collaboratively is in communities close to people's homes will provide effective care and recovery, which is also important for overall health and development. So it's an advocacy action as well as community development action at different levels.
Thank you. There is one question from Rachel, but for the sake for translation, I will also read her comment. This is a huge issue for women and girls, especially during the COVID-19 pandemic, as many of us know that the gender dimensions of mental health is extremely important to address, given the burden of, sorry, let me put it down. Yeah, the burden of care that women and girls play in setting. This is also something that we have to address in conflict setting, especially in gender-based violence. And Rachel comes in with questions, Prof. Helen. How can we ensure the mental health is also addressed adequately in addition to the recommendations you have made in your presentations in pandemic preventions, preparedness, and response, especially given the discussions ongoing now on the financial intermediary fund? Thank you.
Thank you. Yes, well, I endorse the comments about gender and their need to address the protection of women and girls in conflict settings, especially, and in regular, if you like, regular adversity, such as terrible adversity from living in slums and impoverished conditions rurally as well. That integrating mental health care with reproductive care and sexual and reproductive care and providing them equitably is critical.
Yes, thank you. And there is also one proposal or suggestions that to add that the mental health of health professionals is also very important in the episode of pandemic and the global architecture that we are talking for the future. should also accommodate this point.
Yes, well, I think those points are very well made, that the pandemic has brought mental health to the fore, and where we've been able to we've had upheavals in the way economics are regarded in the pandemic. Governments are spending, and we've had upheavals in the way other sectors have worked in the pandemic. So let's trust that there'll be an upheaval and a recognition of the centrality or the relevance of mental health to prevention and being prepared for the pandemic, as well as other climate-related and other problems. I mean, I think the change in thinking about climate action is another example of what can be achieved. And the relevance of this to the young people of the world is an important point here. So young women as well as young men, and mental and health professionals in general. Your point is so well made, that the questions of mental ill health, including burnout, is playing out in all our countries now. And this is part of, I think, curricular development and workforce development throughout our health professionals training at undergraduate and at post-graduation levels needs to include mental health, both in terms of people's own health as well as their capacity to recognize problems in their colleagues and their peers and their patients.
Thank you, Prof. Helen. I read one question. I'm not sure whether it is a questions or suggestions from Pramesti Bimawanti. Mbak or Ibu Pramesti, do you like to mention yourself verbally, or should I just read your comment?
Good. I'll just Pramesti asks, wanting to add a story about the help of mental issues.
Yes.
Agreeing with the general explanation, and coming from a small town in East Java, Indonesia, where it's hard to find mental treatment or to find help with anxiety. And particularly, as you comment there, Pramesti, in a small town or a small community, everyone knows when you go to seek help. And this is the myths surrounding mental ill health are very hurtful here. The idea that it's a personal failing, it's a weakness of character to be anxious or depressed or have some other mental health problem, which is completely untrue. As we know, other myths include that mental ill health might be a kind of a karma or a payback for past bad behavior or punishment from spiritual or from the gods. And with these harmful myths, this stigma persists. And it's, I think, through this general upheaval in thinking about mental health, we must address this. I suppose there can be some help through the greater use of digital technologies, but these need to be considered alongside the fact that the person you see in the primary health centre, whether that's a doctor, a nurse, another health worker, or a lay counsellor, that person is well aware of and understands that depression, anxiety are major health problems and do have effective solutions. Sometimes they may be good listening and some discussion, some openness. Other times they are particular forms of psychological therapies or other therapies that can be delivered, maybe not in the small town, but you can provide that help through special referrals.
Yes, thank you, Prof. Helen. We colleagues and friends, we still have like 6 minutes. So I read here there is one question from Yosi Putri Jaya and also Tatat from Yosi. I just read directly in English. She mentioned that the prevention is in mental health is very important. Are there any shared experience from you, Prof. Helen, kind of prevention care that you see more effective when it is done or implemented into field. And the second questions from Mbak Tatat from Oxfam. I just read it based on the presentations on WHO Comprehensive Mental Health Action Plan 2013-2030. It is targeted 80% countries will system for mental health and psychosocial preparedness for emergency and or disaster. Her question is, where are we currently in terms of the target, and if there is any monitoring mechanism in place to measure the progress? I think she put up a very strategic question, and we will bring that questions from also the next sessions. But over to you, Prof. Helen, to respond to these two questions before
Yes.
we summarize. Yes.
Yes, thank you. I think Afitra was asking, am I correct asking about prevention, what
Yes.
effective prevention there is in more broadly in general?
Yes.
Yeah. So I think that we have quite good evidence, and some of it is detailed in the reports I mentioned, about the effectiveness of prevention in settings. So like working in schools with life skills programs, the changing the school climate. We now have good evidence from India and some other low-income countries that this can reduce the anxiety and depression levels among students as well as teachers. So by the school climate, we mean the relationships between pupils and teachers, and between teachers and the school leadership, so that there is more acceptance, understanding of mental good health, more awareness of what can be done to improve relationships and hence mental health and educational achievement. And the lessening of bullying in schools, the lessening of violence that can be very harmful to students. Those, I think, otherwise working in families to prevent violence, particularly maltreatment of children, sexual or physical maltreatment and neglect of children, and intimate partner violence, particularly against women. These are all known to be, there are interventions for those purposes that are also known, that also produce improvements in mental health. And of course, mental health here is tied up, as we've been discussing, with other ill health, with other health life problems, including substance abuse or HIV/AIDS or other problems, unemployment and so forth. And then at the broader societal level, improving, making any community or society more conducive to mental health through reducing inequity, through reducing discrimination, whether based on gender or other forms, reducing violence. These are all can be expected to improve the reduce the prevalence of mental ill health, improve mental health in communities. Sometimes we don't have trial-based evidence, randomized controlled trials for so much of that, although we now have evidence from poverty alleviation in some countries in Africa that this also produces improved mental health among young women and young men in those communities. But we do know that war is not good for mental health, for example. So we have a mixture of general understanding as well as trial-based evidence from settings and from individual work. And indeed, in terms of the targets for psychosocial preparedness for emergencies and disaster, I don't have the detailed knowledge of where those targets are at the moment, but there are people certainly in the mental health division in WHO and throughout the civil society sector that collaborates with the psychosocial, the recommendations for psychosocial preparedness and support for emergency responses. There are people there who would have good knowledge of that, and certainly that there's been a lot of progress in the last 20 years in that regard, but none of it really is touching the majority yet of the people who are now displaced from disasters and conflicts, as we know, let alone those who will be experiencing problems with climate change and other things from now on.
Thank you so much. We are actually coming to the end of these sessions. There is one question still, but we can continue to discuss this in the next round of the discussions. But colleagues and friends, we will have like 15 minutes break. You can do coffee or use toilets, but very thank you to you, Prof. Helen, because you close your sharing with a very constructive message that mental health is everyone business. And actually, I'm personally very much in agreement with you when you mentioned that advocacy is very important. And in certain countries like Indonesia, and also the things that mentioned by Permawati about the stigma, I think country like Indonesia, we need to engage with non-typical stakeholders, not only health professionals, but also religious leaders. I think we can explore further in our next round of these discussions. And for your information, colleagues and friends, Prof. Helen is being very generous. She will dedicate her time to also accompany us in the next round discussion when colleagues from Philippines and Pakistan will be the resource persons. Time for break, and we will see you all in 15 minutes from now, which is in local time will be 11, yeah. 11, yeah, mas. Now is, I'm a bit confused with timing, but yeah, we will meet you again in 10:45. Yeah, thank you.
Thank you.
I wish you all have refresh break. I do not know whether you have a cup of coffee or tea, but I trust that everyone is quite well equipped now with discussions around mental health. In the second round of the discussions, we will have two distinguished speakers. The first speaker is Ms. Frances Prescila Cuevas. Apologies, Ms. Frances, if I read the names not in the correct way. But we are very glad to have Ms. Cuevas here because she will bring with us the experience from Philippine context. She is the Chief Health Program Officer and also team leader for specialty care divisions, mental health divisions, and cancer control divisions under the Disease Prevention and Control Bureau, the Department of Health Philippines. Ms. Cuevas will be given 20 minutes to talk about integrating mental health in implementing universal health coverage in the Philippines. And then the second one will be Dr.Samrah Mazhar for another 20 minutes. I'm explaining the time plan to all colleagues and friends. And then we will have approximately 15 to 20 minutes question and answer. But yes, Ms. Cuevas, the time and floor is yours.
Thank you. I hope that you can see my slide, right?
Yes, clear.
Okay, thank you then. I
Full
would like, yes, thank you so much for the invitation today. We're very happy to be participating in this dialogue, and we are hoping that we can share something that we have done in the Philippines. And how did we integrate mental health in the implementation of universal healthcare in the Philippines? So I would like to start off by saying that the pandemic actually has provided us with a reality check that there is something actually that needs to be done for mental health services in the country. And not only that, but also in general, in the provision of and the delivery of health services in the Philippines. And I just would like to show you this slide as I start. This is a scientific brief that was provided to us by WHO in March of this year. And it says about the mental health and the COVID-19 early evidence of the pandemic impact. And if, as you can see here, that the pandemic really brought out a lot of problems in the country. I will not belabor this. It's just to show all of us that indeed the pandemic has brought to fore the problems of mental health, not only in the Philippines, but also all over the globe. I also would like to share that maybe even with the pandemic, we were in the right time. We have a right timing when the pandemic struck, because we were already working on two very crucial laws in the country, which would take care about mental health and specifically ensure that this is implemented well and being covered in the universal health care. So we have a law that was passed in 2018 for the mental health and a Universal Healthcare Act in 2019. I also would like to say that these are new laws, and we are doing progressive realization, if you may say that, on all of the intentions and the objectives of the law itself. So what I will be presenting to you today will be some of the things that we have been doing and some of the things that we still need to do. So let me start with the Republic Act 11036, which is the Mental Health Act, which was signed in 2018. And this law wants to establish a mental health policy that will enhance the delivery of an integrated mental health services, promoting, protecting the rights of persons utilizing psychiatric, and in the Philippines, we are including neurologic disorders as part of our mental health efforts, and psychosocial health services, and of course, providing support in the delivery, in the implementation of all of these intentions. And we have, in this law, we have actually 6 objectives. Governance, we would like to ensure that we'll have effective leadership and governance. We'll be able to set up an integrated, effective, comprehensive mental health care system and make sure that these are integrated in the basic health services. Of course, information systems, research base is supposed to be provided, and rights of persons utilizing all of these services should be observed, and we have to integrate all of these interventions and promote mental health in 3 major settings: the educational institutions, workplaces, and in communities. And I would like to show you that in order to be able to ensure that we are implementing it correctly, we developed a strategic framework that will be until next year, 2023. And our strategic framework actually is guided by the Lancet Commission on Global Mental Health and Sustainable Development, the one which Professor Herman earlier also mentioned. And with the mental health law already in place, we were very fortunate that in 2019, before the pandemic struck also, we were able to pass the Universal Healthcare Act of 2019. And this law provides for an integrated, comprehensive approach to the delivery of health services without causing financial hardships for people. It should be whole of system, whole of government, whole of society approach. People-oriented approach needs to be provided. And we have in the implementing rules and regulations the objectives of progressively realizing that all stakeholders, key agencies, everyone in the country actually has a role in ensuring that universal health care is being provided and ensuring that all Filipinos are being provided with equitable and quality affordable healthcare, goods and services, and protected against financial risk. So with these objectives, I would like to say that the objectives of the mental health law and the objectives of the Universal Healthcare Act are actually in sync with each other. And very specifically, would like to mention that as part of the law, it provides service coverage for all Filipinos, preventive, promotive, curative, rehabilitative, palliative care, medical, dental, mental, emergency health services that should be delivered population-based, individual-based services. So with this service coverage provision of the universal health care, that is also the mandate of the mental health law. And the financial coverage also is something that is mandated in the implementation of the Mental Health Act, and would like to be able to tell you later where we are providing financial coverage in this regard. So just to be able also to just say that we are in sync. You know, the two laws are actually in sync, and we are integrating all of this in the universal healthcare that we have, implementation of universal healthcare in the country. What we are doing at this point in time is that we are developing a community-based mental health program, and we have already the framework in the design. We're working on the standards and guidelines. We're actually scaling up this mental health program in the middle towards the end of the year, so that by next year, all over the country, we'll be able to roll out community-based mental health program. And we are also at the same time doing capacity building for primary healthcare facilities. We're using the mental health gap intervention guide, and we are targeting finishing all of our primary healthcare facilities in the country by the end of 2022, so that they will be ready for the implementation, full implementation of UHC and Mandana's ruling that we have. We also are at this point in time working on the rules and regulations in licensing mental health facilities. The mental health law is providing for the licensing of all hospitals in the country. So whether, regardless of what level, there should be a mental health service that will be provided, either an outpatient service or a full-blown psychiatric unit will be there for as long, depending on their capacity. But we are doing this, and hopefully by the end of the year, we'll have those rules and regulations in place, and we'll be rolling them out next year. So we also have a medicines access program for mental health. We are providing as part of our capacity building medicines. So we're buying medicines as to supplement the budget of the local government units, and we're providing them medications for the purpose. And we're also have integrated a mental health information system, the primary care level, and we call this the iClinic Cs. We also are integrating strategies in promoting mental health in educational institutions, workplaces, and communities. We actually have department orders in place for the private sector, in the workplace, in the private sector, and in the public sector. So all of our agencies of government, all of the private sector workplaces are supposed to be able to provide mental health care services and promote mental health in their own areas. And we are now also using the promotion of playbooks for the use of local government units to promote mental health in their own areas. We also have included in our mental health messages, care for yourself, care for others. So we have this overall health promotion campaign of Todo Pito. That's 7 different types of health issues that we are looking at and promoting heavily in the country, and it includes mental health. We also have a self-care app, which is the Lusog Isip app, which people can use for this purpose. We are also providing financial coverage. We are developing, and hopefully by next year, as part of the rollout of the universal health care, a consulta package will be provided. This is a primary care service package, an outpatient benefit package that will include mental health services. We are also developing a field health benefit package for very specific for mental health. So can be accessed in primary care, outpatients, and inpatient care or hospitals. Another area where we do a lot of work also is in the delivery of, in the strengthening of policies and systems researches. And we are establishing mechanisms to strengthen our governance in this area. Thus, we have, as I said earlier, we have developed a framework. We have a full-blown division already working on mental health in the country. And then we have, we're finalizing all of these circulars and policies to include in the seal of local governance, mental health services in all local government units. We are working very well together with a lot of stakeholders, both government and non-government institutions. And one of the areas that we are working on also is the protection of the rights of our service users. We have established internal review boards. We have guidelines on obtaining informed consent. We have capacity building on quality rights provided by WHO. We have just provided for guidelines on the ethical portrayal of suicide in media, and all of these are being made available to the public and all the stakeholders. We are also strengthening our research capacity by making sure that our premier mental health facility, which is the National Center for Mental Health, will be a observatory center for mental health and neurologic services in the country. So we're providing support for their reorganization and ensuring that they are able to do the mental health information systems. And we are also providing for the establishment of the suicide registry in the country. And we also have a very good, I think, research agenda for mental health. Another area where we are working with in the delivery of mental health services and Universal Healthcare Act is in the emergency response that we have. So we are very, we have 5 areas actually in the intervention that we have for mental health. And one of the areas that we have is when people experience extreme life experiences, we are providing them mental health and psychosocial support, particularly during disasters and emergencies. Like, for example, and we are using these IAC guidelines for MHPSS, but I'm sure all of us are very familiar with. And we also have crisis hotline, the National Center for Mental Health. And this has been very valuable to our people during the pandemic, because they were able to reach thousands of people calling during this pandemic period, the crisis hotline. So we hope that we have prevented many people from suicide attempts and thus able to recover. We also have a lot of activities that we did during disaster time, in particular during this area, during this time of the pandemic. There are some, these are some of the activities that we have. We have one-stop shops for returning overseas Filipino workers that we have, even at the airport. So we already do psychosocial assessment and provide some support and all the other session and all the other provisions of MHPSS in different areas of the country. We also were able to provide for our healthcare workers, and this is one of those areas that we will still pursue even as we transition into the new normal. We realize that our healthcare workers are very important, and we are supporting them in terms of ensuring their wellness and their health by providing them with support, financial support through our Bayanihan laws, and also stress management when they are working in the facilities. We also have a lot of social media engagements, and thus we, as I said, also mentioned earlier, we have provided for a guidelines for media and suicide, and we hope that, and we know that these are things that all of us will have to follow. Okay, with all of those things, those are just some of the specific things at this point in time that we are working on, and how are we all integrating them in the healthcare, the universal healthcare efforts that we're doing. First and foremost is that we are doing Omnibus health guidelines, and in these Omnibus health guidelines, we're no longer doing a vertical approach, but an integrated approach where all of the health guidelines, standards of care that the child needs, adolescents would need, and the adults and the elderly would need are placed in just one guideline. And of course, mental health standards are care standards are included in all of these areas. So the Omnibus health guidelines will be out probably in the middle of the year. So thus we've been working so hard on finishing these guidelines. And these guidelines will be doing capacity building modules to make sure that the guidelines are going to be implemented well, manual of operations, and all of these are integrated into one. So there's no longer going to be vertical programs, but integrated programs across the life stage. We are also organizing province citywide healthcare delivery systems, because this is where the services will be provided. So provinces and cities, we have advanced universal healthcare implementation sites. And so whatever projects that we are doing now, we are putting them into the universal healthcare, advanced universal healthcare implementation sites, just to see how we can integrate all of these things in their healthcare delivery system. And as I mentioned also earlier, the consulta package is going to be, it's not just for mental health, but this outpatient benefit package actually is a package that will include all the other services that will be provided at the primary care level, which will include mental health. So this financial coverage can be availed by people doing consultations at the primary care level. So
It's
just to show you, and I'm going to be ending in these 2 slides, our ways forward as we go along is that we would like to be shifting from specialized services to integration, of course, into general health and community settings, thus ensuring that we will have a stronger mental health system for the future. We cannot afford anymore to be in silo, but to be integrated well into the system. And we would like to be able to, in the end, realize this mix of services for us, that we have communities at the level of the community, at the level of the self. We are able to provide our own mental health care services. We are able to provide step up services in the communities if available. And then we are integrating mental health services into primary care. And for those which we cannot, intervene with efficiently at the level of primary care, then we have hospitals that are licensed to provide services in this regard. So I hope that I have provided you with a glimpse of what we are doing in the country, and mabuhay tayong lahat. Thank you very much.
Thank you so much, Ms. Cuevas. You are very rightly in the timing. And we will straightly moving to the third speakers, actually, Dr. Samrah Mazhar. Let me introduce her to our audience. Dr.Samrah Mazhar is a public health professional with an experience of more than 20 years. She is presently working as Deputy Director at programs level at Ministry of National Health Services, Regulations and Coordinations in Pakistan. Her domain of work is mainly non-communicable disease, mental health or substance abuse, and tobacco control. She is the national focal person for WHO Framework for Tobacco Control, or VCTC, and illicit trade. She has engaged with multiple actors working for NCDs and mental health in the country and undertaken many initiatives. She has spearheaded the development of first national action framework for non-communicable disease and mental health, which going from 2021 and until 2030 for the country. She is also working for the development of National Tobacco Control Strategy, and she is also the member of National Task Force for Mental Health during COVID-19 pandemic. She was on the front lead of the Ministry of Health for preparedness and response activities. Her previous experience in the public sector is international health emergency preparedness and response, and also program management. She has represented at many national and international forums. I think by reading her brief bio, we feel lucky that Dr. Samrah will be with us. And Dr. Samrah, you will be given 20 minutes to talk about your subject from the Pakistan context. Time and floor is yours.
Yeah, thank you very much. Thank you. I thank the organizer for inviting me and for giving this intro of me. So I'll share my presentation. Yeah, can you see it, please?
Yes, it's coming up. Yeah.
Yeah, thank you very much. So I'll be talking about the mental health in Pakistan, what is the situation and what initiative we have taken. As you know, Pakistan has a large population of around 220 million. And the prevalence in Pakistan, this is according to the Global Burden of Disease 2019. And according to this, around 25 million people suffer from the mental health diseases of any kind. So these are the prevalent cases of Pakistan. This picture shows our Honorable President of Pakistan, who has a keen interest in the mental health issues in Pakistan. And in 2019, an expert group of mental health and other government officials, they met him, and he directed for establishment of an expert group on this mental health, and taking a public mental health approach across the lifespan. This group also focused on the maternal mental health and child and adolescent mental health. So there was a mental health task force established. Basically, it was for mental health issues, but covering also the substance use issues. So there were three further technical groups under these. These were the awareness group, the treatment and rehabilitation, and legislations to oversee what legislations are there and what more are needed. So it covered both the mental health disorders and also the substance use disorder. So the first task taken by this task force, it was the scaling up the WHO school mental health program in public schools of Pakistan. And there was a lot of activities went on, and there was consultative workshop with over 90 stakeholders to scale up the mental health services in low resource public schools of Pakistan. Later, the private schools also joined this program. So there were various activities. The teachers were trained how to assess the students' mental health situation, and linking it with the parents, and talking to them and informing them, and vice versa. The parents also discuss with the teachers that what problem they face with their children. So these the WHO guidelines were adopted to conduct previously during the COVID. It was online training courses, and we trained around 320 teachers from the public schools in 2 districts. So these districts has a large population. They were near the capital. So these teachers were trained. The training of teachers on early identification and management of mental health problem in school children. So it was found that the 27% children and adolescents at risk of mental health problems were identified by their teachers. So it was a pilot program, but later the whole of the province, the education department and the Minister of Education, he was also has keen interest in this, and so he was very pleased with this initiative. So then there was a the global framework for the accelerated action for the health of adolescents, and it has a component of mental health. So there was in 2020, there was a consultative national workshop for the development of national strategic adolescent health and development plan using the global accelerated action from the health of adolescent. And in this workshops, other sector also attended. Apart from the health, there was the Ministry of Human Rights, Ministry of Social Welfare, and other, and it also has a component of violence and for these adolescents, so how to manage these problems. So the aim of workshop was to identify priority health and development issues affecting the health, including mental health and welfare of adolescents in Pakistan, using the AHA framework of WHO. So what are the steps towards universal health coverage in Pakistan? So Pakistan is the first country in the region to adopt the disease DCP3, that is Disease Control Priority 3, and developing an essential benefit package for the universal health coverage. And we were able to include mental health management. We'll see further what we can do this in this program. But this is the integration of mental health in the healthcare system. So our ministry first developed a national health vision, which was in 2016 to 25, and it contains mental health as a priority. And then an action plan was also developed in 2019 and 23, which also contains the mental health as a priority and how to integrate into the primary healthcare or into the system. Because treatment care is given at only the tertiary care hospitals where the psychiatrists or psychologists have been appointed. So the most important development is the non-communicable disease and mental health action framework, which is finalized in 2021, and it covers till 2030. So NCTs are on the priority agenda, but if we take mental health, so either we take it separately, then the expert thought that it is one of the non-communicable diseases. So it's instead of taking it as a separate subject, it should be integrated with the other NCDs, the 4 major NCDs, and the action plan should be developed. So NCDs and mental health agenda has been recognized in the policy document as a matter of priority. So development of this NCD and MH action framework is yet another milestone achieved entailed challenging and strategic vision for tackling mental health issues in Pakistan. So to transform the national health vision into reality, one of the key actions was to develop national and provincial area-specific UHC benefit packages, which consist of an essential package of health services that is called EPHS, and an intersectoral intervention and policies. The essential package of health services has been finalized and it is being published. And the intersectoral intervention policies are still to be finalized, and it was delayed due to the COVID pandemic. So the objective of this EPS document is to define which services are to be covered through 5 different platforms, both through public and private sector, for all people across the country. So as you know, number 1 is the community level, then it is the primary healthcare center, then first level hospital, and then tertiary hospital and the population level. So these are the 5 levels in this benefit package to deliver UHC to the citizen of Pakistan. So which intervention has been prioritized for the primary healthcare level, both at federal and provincial level? It is the management of depression and anxiety disorder with psychological and generic antidepressant therapy. So at primary healthcare level and at first level, both of these disorders have been not been addressed. These are covered only in the tertiary care hospital. So linking the primary healthcare with the tertiary healthcare level, first at the primary healthcare level, they can, because these two they can manage at this level with the assessment, screening, and treatment. And then if there are some other problem, they can refer it to the higher facility. So because a large number of population is at the rural area, 64% of the population in Pakistan lives in the rural areas, so they are going and visiting these primary healthcare level facilities. So then there is a proposal for National Mental Health Helpline. We are working on this with our partnership with some private organizations to pilot a national mental health helpline concept via public-private partnership. This will allow Pakistan to ramp up access to mental health services and reduce barrier to care. And the vision is that in the future it will be integrated into this UHC program, and through this mental health helpline, a lot of coverage. The coverage can be increased, and those who are not could not attend the facility or their families are not bringing them to facilities, they can be benefited from this helpline. So there are multiple challenges which we faced and which we are facing for mental health management. So there are lack of qualified mental health experts at all level of health facilities. For a population of 220 million, only few specialists of psychiatry are available. So there are lack of basic infrastructure and rehabilitation center across the country for mental health services that provide 24-hour assistance to public. There is a lack of integration of mental health disorders as a core service in primary healthcare. So this intervention of addressing anxiety and depression will, I think, cover this challenge. Less training opportunities for general physicians, medical postgraduates for addressing mental health issues. And most of the postgraduates, they do not opt psychiatry as their subject. Because there is also a stigma related to the being a psychiatrist or psychologist still in Pakistan. So for we have like conducted training of MHGAP of WHO, which is a very good guideline treatment and training opportunity for the general physician or the primary healthcare. There is a lack of indigenous research. It is had been major hindrance to the rational planning and allocation of resources. So clinical research has been going on, but for preventing and promotive measures, there has been less research done. So substance abuse and drug abuse is also has a great contribution in this mental health disorders. So there is a lack of authentic data on demographic, psychographic causes of drug abuse and the factors that drive drug prevalence in society, especially among adolescents. There is an absence of sustained anti-drug media campaigns. There is a lack of awareness of mental and physical hazards of drug abuse amongst the youth and parents. No proper national curriculum or program on dangers of drug abuse. Time to time, efforts have been made for awareness campaigns, but not integrated in the education or other departments. There is a lack of coordination between the different ministries and provinces to come to a solution for this problem. Sorry. So the mental health task force was a solution to this. And we brought all the experts from all the areas to one platform to work for this drug use issues. So what can be the recommendations and the way forward? We should strengthen the health system capacity to provide essential mental health services and diminish treatment gap. Engage electronic, print, social media to raise awareness against this mental health disorders. Develop enough strategies aiming to reduce the impact of drug use and drug-related activities in adolescents. Conduction of survey on mental health indicators, including drug and substance use addicts at national level and provincial level. Recently, we have done an online survey for the youth for these mental health issues, and the results are awaited. So we'll be sharing once it is finalized. The most important is to raise awareness in general public and educational institutions about the significant negative mental and physical health effects caused by the drugs and narcotics use. So this is also one of the agenda to take forward for addressing these mental health issues in the youth. So I thank you all for listening, and thank you for giving me this opportunity. Thank you very much.
Thank you so much, Dr. Samrah. Colleagues and friends, because Dr. Samrah is finishing a bit of ahead of time, so we will have, instead of 15 minutes, we will have 20 minutes of question and answers. I will give chance to first two questions and will give floors to them for responding our questions. I open up the question and answer sessions for now. You can type down in the chat box or raise hands. Okay, Mbak Akila. Time.
Yeah, thank you very much, Mbak Arsinta and other colleagues. Let me introduce myself. My name is Akila. I'm from the Prakarsa. One of the questions that I ask for all the speaker, is there any suggestion from all of you to increase the political will of G20 members to integrate these mental health issues inside universal health coverage, especially in financial coverage issues? Because as we know that the importance of universal health coverage are addressing to this G20 platform since 2019 in Japan presidency, and all G20 members are constituted to that commitment. So that's all my question. Please feel free to respond. Thank you.
Yes, thank you for very strategic questions. I give opportunity to another one before I give Ms. Cuevas and Dr. Samrah to respond. Another question? Okay, Mas Adit.
Thank you, Dr. Samrah, Ms. Cuevas, and Prof. Helen for the presentation. Actually, I want to ask a question to all speakers as well. Based on your experience and knowledge, actually, how many percentage of the ideal budget for a country to finance mental health, especially? And what to say, how the government think that it is important for the government to finance mental health? That's all my question, Pusinda. Thank you.
Thank you. Thank you so much, Mas Adit. Dr. Samrah and Ms. Cuevas, time is yours for responding to questions from the floor.
Yeah, can I start? I'm sorry I did not get the question, the first question, but I would like to answer probably the second one. In the Philippines, one of the indicator actually that we have for the strategic plan is that we will have a 5% of the total budget of government or health government should be placed for mental health services. As of the moment, we have reached already 3.5% of the budget of the health department is already placed for mental health. So we still have some percentage to go, but I'm sure that with the current interest really on ensuring that mental health services in the country are going to be provided, we would be able to reach that goal. I'm sorry, but I did not get the first one.
The first one is about political will, because integrating mental health in UHC has been on the table since Japanese presidency in 2019, according to our colleagues here, and how such statement or recommendation actually gives a move concrete implementations. How do you see it, Ms. Cuevas and Dr. Samrah, from your own experience?
Yeah, I think we were fortunate. I mean, in the Philippines, we were fortunate because for 30 years or so, there has been a lot of work, advocacy work already that has been done by our stakeholders in terms of pursuing for a mental health law to be pushed in Congress and in the Senate, and we were happy, and that's I think the the perfect combination. That, you know, the push, the strong push from mental health advocates, the private sector, and also at the same time, the government already is very much aware of the needed push to ensure that mental health services are going to be provided. So I think that there was the right timing. So it was in 2018, 2017, 2018, there was a lot of work that was done, and yet it was, I think, easy because the stakeholders, there was some compromise on our end also with them. So I think it's very important for different stakeholders, the advocates, to be really working with, not in an adversarial mode, but ensuring that everybody is at least on the same level, on the same stage. So I think that's what happened in the country. That's the reason why we had this mental health law enacted in 2018 after 3 decades or so. And also the universal healthcare really is something that has been already much talked about, and and it was really pushed so hard also by our legislators. Thus, it was done at the same time, and we're just so glad, and so I think that's the right timing, I would say, for our country to have all of these laws, done in almost the same time. I hope that answered your question.
Yes, thank you, Frances. Dr. Samrah?
Yeah, thank you. For the first question, yes, there is a need to increase the political will at the G20 members to integrate this mental health issues inside UHC. And Pakistan has been able to initiate this, but just 2 disorders, these are the, I think we have more of these issues. So anxiety and depression has been added in the universal health coverage, but financial issues coverage is still a problem, because this UHC package has been started with the support of World Bank, like some grant and some soft loan, but the government should take responsibilities of their own financing, and should give more importance to the mental health issues. There is a budget for the treatment part, like every tertiary care hospital, and there are separate hospitals for mental health issues. There is budget allocation for them, but for prevention and promotion, there is no dedicated budget or for awareness raising. As far as the second question, I agree with the first speaker that yes, a dedicated budget, which should be like 5% of the total budget. But in Pakistan, we have the total spending on health is still less than 1%. So you can see, and if mental health is not on the priority, so it is even more less than 1%. So every year we struggle to increase this budget. But for treatment part, this is available for all the hospitals, but for other components of addressing mental health issues, the budgets are not available. So we have to take support of the other partners or organizations. But as a system, we don't have a budget for this. So, and also, even if we have budget, I earlier informed that in Pakistan, there is a lack of trained human resource to address the mental health issues. So the both issues are side by side. So this is from my side. Thank you.
Thank you. I do not know whether Prof. Helen would like to also contribute to respond, or can we move to next question? Prof. Helen, do you want to mention something?
Well, thank you very, very much. I think these have been an excellent discussion, and appreciate the presentations too. I suppose, I think just to support what has already been said, that we need to understand that mental health is a full part of public health and universal health coverage, and that by leaving it out of provision, out of policies, we weaken the whole health and social service and response sectors. And in terms of the first question of increasing political will, I think just as has been said, it's the unity of approach that's critical. And I'd particularly draw attention to providing a voice to the people with lived experience of mental ill health and their families. And for instance, the World Psychiatric Association has recommended that governments and professional associations provide financial and moral support to associations of families and consumers or people with lived experience to make sure that they do have a place in advocacy, seeing that as critical to developing the political will. And along with that, making use of champions like Malala Yousafzai and the other, and the young women involved in climate change. And we get the same leverage from champions in the community. And the other side of it is making sure that the message is very clear. We have now so many international reports and commissions that are showing us that there is evidence for the effectiveness of these interventions. There's evidence of the outstanding need and how this is such a drain on development and will impede the achievement of sustainable development goals. So there are incentives for people at policy making and government levels, people at community levels and individual families to support this idea, including the response to emergencies, as we're seeing how much damage there is when the response cannot be achieved readily and quickly.
Thank you so much. For the interest of time, I will only give the opportunity for one questions, and we have one question here from Dwina Lila from Yakum. I summarize her questions. She is asking about how is the engagement of civil society organizations in mental health care from the perspective or from the experience of Philippines and Pakistan. Ms. Kouafes and Dr. Samrah, please respond to these questions.
Okay. How is our engagement?
The engagement
always,
of civil society organization.
Okay. I think it's because we treat our I mean, I'm from government, and we respect so much our partners, the advocates, particularly the mental health advocates in the country, and we value their experience, we value their expertise, we value their desire, to push some their advocacies, which is really aligned also with our advocacies, and so we work things out. Now, as I said earlier, I think it's just because sometimes advocates have really they're very strong in pushing for something, but government sometimes cannot really go in the same pace, probably because there are some issues the government has to work on to ensure that it is within the systems that needs to be done. But what I'm saying, actually, it's really aligning ourselves with our various stakeholders. That's very important. This is a personal experience on my end, and this is something that I bring into the conversation because of my own personal experience. It's really, just making sure that whatever it is that they are putting on the table, government also should take a look at, and not just, sweep aside, but make sure that there's alignment of the goals. Maybe not in the same framing that they wanted it, but in a framing that everybody agrees on. So I hope I have I have said that, and that is put across to you. It's really just aligning ourselves, I think, with our advocates. So I'm coming in here into this conversation from a point of view as a government person, and this is our experience with them. As I said earlier, it has been 30 years, and even more so than 30 years. And it's only at this point in time, because everybody already has been aligned, and everybody now sees that the importance of this. So there.
Thank you, Dr. Samrah.
Yeah, thank you. Yes, I agree that the civil society organizations have an important role for addressing these mental health issues. And they are best for creating awareness, advocacy to the political persons, and also creating awareness for this stigma related to the mental health issues and seeking care. So in our government, we are working with the multiple organizations, especially this for school mental health program, and also for this drug use prevention. So a lot more are working in the drug use prevention. So their role is very important, and we have partnership.
You are muted.
Sorry. One thing, the last thing, we are like working for this mental health helpline, and we'll be establishing this with one of organization, this Taskeen Foundation. They are also attending this meeting. So we are working with the CSOs in every area to address mental health issues. Thank you.
Thank you so much. I think the statement from Dr. Samrah is a very strong takeaway especially for us, the C20. And I myself feel quite humbly to say that I won't be able to conclude the very rich information sharing since this morning started with Prof. Helen, Ms. Huefas, and also Dr. Samrah. But rather, I would like to highlight a few strong words that mentioned by our speakers. And please forgive me if I left out some others, but things that are striking my mind is that statement about mental health is everyone's business, and the fact that it is the issue of universal human right protection. It is not only things about health or medicals, but the human rights protections and to the highest attainable level of physical and mental health. Therefore, strengthening capacity of communities to respond to mental health is a key. The number two is integrated mechanism and collaboration across sector, as well as shifting the approach from the institutional based to community based care, repeatedly saying by our speakers. And also a point, a very strong, if you feel the impressions that there is a good dynamic will to balance between existing good policy in place, as well as combining or articulated the action-oriented move in the country or in the field level. So experience from the Philippines, from Pakistan, actually was it presenting or showing us that the good policy in place are not enough, and more importantly that we need to have the actions implemented. And colleagues from the floor, Matata from Oxfam, as well as colleagues from the chat box like Ms. Marina Sabayang also mentions, don't forget about the monitoring mechanism of those policies achievement target, as well as the fact that mental health is actually lifespan interest, not only the adults, but more importantly is also since a very young age. And the last point is very particular examples that Pakistan has shown about creating the UHC benefit packages. Even though Dr. Samrah mentioned about humbly mentions that this is something that still focusing on some areas of expenses like curative, but it is showing that the package is actually not only from the essential but also covering intersectoral intervention. So again, the word of cross-sectionality, cross coordination, cross collaboration is very important. And also the fact that electronic social media and printing media is very helpful to raise awareness, but not only raising awareness, but also strengthening the health system capacity. In fact, it is also used for monitoring the progress by conducting survey, etc. I think I will leave. I will stop in that point, and even though there are still some questions, I think because in the beginning, the coordinator of C20 vaccine health access and health working group also mentioning that our program will be until tomorrow. So the any questions, any suggestions, any reflection will be welcome. And but I again thanking our speakers very much, and your contribution really help us in focusing our mind. And the way I see the challenges that presented by Dr. Samrah, by Ms. Cuevas, as well as by Prof. Helen, that's not remaining as challenges, but I think it really helped us, the committee here, the ones that discussing in the C20, what kind of recommendations and what kind of declarations that we should put in our policy pack. Thank you so much. I will hand over the last sessions because we still have 10-15 minutes for my colleagues, Aditya Setiawan, to facilitate us in having interactions as well as engagement, so that we know we have something to bring home, to not bring home but bring into the the coming discussions. Mas Adit, floor is yours.
Thank you, Bu Sinta. Thank you, Bu Sinta, for deliver the session to me. For this session, actually, we want to provide or to collect the takeaways from the participants of the side events. So hopefully later on we can use this recommendation or use the follow-up things to complete or to add something in our policy pack or documents later on. I will share my screen, and I want you guys to open www.menti.com, and please the code of 83865782. And when you have entered the code, later on you will see questions about how mental health and universal health coverage relevant to C20 vaccine access and global health priorities. Since one of the priorities in the C20 vaccine access and global health is about global health architecture, and inside it there is a universal health coverage. And through the session and through the presentation provided by Prof. Helen, Dr. Sharma, and Ms. Frances, based on your understanding, your takeaway, how do you think that mental health and universal health coverage relevant to our priorities about global health architecture and especially the universal health coverage?
Five minutes, because we have another questions, Mas Adit.
Yeah, please go to www.menti.com and put the code of 8386 5782 and fill the questions. Thank you. Still only one participant who have failed, or if you have difficulties, you can type it in the chat box as well.
We can type as many as we can. Okay, Mas.
2 more minutes, please. Okay, 1 more minute. Please fill it out and we can go to the second questions. All right, thank you everybody for filling up the form and we can go to the second question. It is actually about the reflective things uh, based on your understanding, your takeaway from this session, from these side events. Please mention ideas or how do you think to integrate mental health in your own context. For the example, if I working in the disaster or emergency, later on, if disaster happens in my own place or the place where we assist, we can provide mental health psychosocial support, for the example. Or since mental health is a mainstream issue, it also can be mainstream into the other aspect as well. Thank you. We have 5 minutes for this, ya, Sinda. Okay, 3 more minutes, please. There are still 6 people who have filled the forms. All right, thank you everybody for your willingness to fill out the form. We will use this later on for our inputs as well as for our reflection on the side events on mental health and how it be integrated to the universal health coverage. We think that's all from us. I give it back to the master of ceremony. Thank you.
So thank you everyone to be involved in this productive meeting. I should remind you to all participants online that we will use the same link address, so you can leave the room meeting now and then log in at the same address. So for those the attended participants here in these rooms, we are now we're now having time for lunch and breaks. I think the time is for berapa? 1 hour, and then we will meet here at 2 p.m. I'm sorry. We will meet here again at 3 p.m. Thank you, everyone. Have a great day. We will see you again. Thank you.